Good morning, everybody. Welcome to Grand Rounds. I'm Kaz Nelson, Vice Chair for Education, and it's my pleasure to welcome you here today. We have an invited guest speaker from across the street over at HCMC, and I just wanted to provide a little bit of context that in addition to Grand Rounds that we present on innovative scientific developments or research developments, we also want to be continuing the conversation when it comes to sharing and dissemination of innovative clinical models and clinical work. And so we've invited Dr. Stamatis Zeris today from HCMC, who is one of our teaching track faculty members located at that site, doing a lot of work with residents and medical students, and interested in advancing teaching and clinical models, and wants to share that with us today. And I think it's particularly well-timed as our department embarks on this process of strategic planning in the clinical realm, lots of discussions evolving around ideas of innovative models of care, embedded psychiatric care in other settings. And so it's extremely well-timed, and I'm really looking forward to this. I wanted to give you a little bit more information about Dr. Zeris. He's the Medical Director of Primary Care Behavioral Health at Hennepin County Medical Center, a staff psychiatrist in the Adult Outpatient Psychiatry Clinic, and the first episode psychosis program at HCMC in the Department of Psychiatry. He trained at the University of Washington Psychiatry Residency Training Program and is an assistant professor of psychiatry at the University of Minnesota Medical School. He specializes in the care of persons who suffer with serious mental illness, including schizophrenia and borderline personality disorder, in the public psychiatry setting. In his leadership and clinical roles at HCMC, he's working towards increasing access to evidence-based mental health care to the broader population by implementing the pillars of collaborative care in primary care and building effective collaborative relationships between primary care and mental health professionals. And by definition, this is building collaboration between us and HCMC. And so it's my pleasure to welcome you here. Thank you.
All right, thank you for that introduction. So I'll be talking about our primary care behavioral health program and integration into primary care in our public health system, Hennepin County Medical Center. So I'm going to describe the principles of collaborative care. We'll recall the evidence of collaborative care and discuss real-world challenges in implementation in a public health system. And I'm just going to give you guys a general overview of the flow of the talk, since I'll be covering a lot of information. First, I'm going to define the problem, which is lack of access to mental health care. I'm going to discuss the theoretical foundation and evidence base for integrated collaborative care, and describe what it looks like on the ground, and we'll finish with the work we've done at HCMC. So starting with the big picture, where are the mental health services in the U.S.? First, it's notable to see that most people in the population who have a diagnosable mental illness don't receive any care at all. That's 59% of the population receives no care. 41% that does receive care, most of them receive their care in the general medical setting, 56%, and 44% of those with mental illness receive their care in specialty mental health care. So primary care has become the de facto mental health clinic in the U.S. 64% of all outpatient visits for the elderly occur in primary care. Nearly half of all antidepressants, sedatives, and hypnotics were prescribed by primary care providers, as well as 20% of all antipsychotics. Less than 20% of patients with addictions will ever be seen in specialty care. And not surprisingly, 90% of patients prefer that their psychiatrist and primary care provider communicate about their health care. And so this is what our current system looks like. We are very siloed. Mental health care lives in its own world, primary care in another world. Addictions, for some reason, isn't even part of mental health most of the time in the community, and social services is in yet another silo. So why should we as psychiatrists care about primary care? Well, there's not enough of us to meet the need in the community. There's 7.4 psychiatrists for every 100,000 residents. That was in 2013. The HCMC, or healthcare provider shortage area definition for the threshold for a shortage area is one psychiatrist for every 20,000 residents. That doesn't actually describe what would be the ideal ratio, and I haven't been able to find an American standard for that, but the Canadian Psychiatric Association tells us that their ratio is one psychiatrist for every 8,400 residents. So in order to meet that need today, we would need 2,800 new psychiatrists to be trained immediately. Further magnifying the problem is that half of all psychiatrists just do not accept insurance at all, and only 25% of all psychiatrists accept public insurance like Medicare and Medicaid. The other issue is that we have an aging psychiatric workforce. The median age in 2003 was 55. And another part of the problem is that we're not repleting the shortages felt by attrition and retirement with new psychiatrists. We only have 2% of medical students going into psychiatry per year. The other disturbing trend is that the population of U.S. Practicing psychiatrists has been declining over the last 10 years as compared to other similar specialists like neurology and primary care. There we go. So the other thing you'll see here is this is the U.S. Broken up into quartiles of psychiatrists per 100,000 U.S. residents, and you see that there's a pretty big disparity along geographic areas for who has access to a psychiatrist. The dark blue are the areas where there's way more psychiatrists. New England, New York has a pretty adequate supply of psychiatrists with 11.9 to 55 psychiatrists per 100,000 residents. And then there's enormous swaths of the country where you only have 1.7 to 4.9 psychiatrists per 100,000 residents. Not only is the disparity along geographic lines, but also along socioeconomic lines as well. If you look below in that, the figures highlighted in green, you'll see the Gini coefficient for each specialty. And so the Gini coefficient is a measure of income inequality or any resource inequality in a given population, 0 representing perfect equality for a given resource, and 1 representing perfect inequality for a given resource in a population, meaning that one person in that population has access to all of that resource or all of that income. And you see that psychiatrists' Gini coefficient is highest when compared to neurology and then versus primary care. You see the trend in red of the decline in psychiatrists over the last 10 years. There's been a 10% decline in psychiatric workforce, whereas neurology has increased by 15%, and primary care seems to be sort of just breaking even at 1.3%. And so no psychiatric grand rounds, I think, is complete without a New Yorker cartoon. This is oftentimes how I think primary care docs, patients, and frontline mental health workers like police officers feel when dealing with patients in crisis in the community. I'll read the caption in case you can't see it all the way in the back. We couldn't get a psychiatrist, but perhaps you'd like to talk about your skin. Dr. Perry here is a dermatologist. So I'm going to switch gears now and start talking about the theoretical basis for collaborative care and the evidence base for it. The theoretical basis, it's based on the chronic care model. The chronic care model was designed to address chronic diseases on a population level. There's 6 components to it, and the goal is to deliver an informed, activated patient having productive interactions with a prepared, proactive practice team, resulting in improved outcomes. So you see that in that bubble there, you've got the community and the health system, which is part of the community. And you need the health systems to be interacting and integrated with social services and other community resources, and the health system to have leadership that values population care and shifts resources to this model of care. Self-management support refers to optimizing the population's ability to manage their condition on their own. An example of that is the free quit line for tobacco cessation or online CBT modules for anxiety. Delivery system redesign refers to reorienting the healthcare provider's approach from a rescue medicine reactive approach to a more proactive preventative model. Immediate decisional support refers to obtaining decisional support from a expert in real time rather than sending a patient for the traditional consult to another site. So the consultation and the decision support is then separated by time and space, and this is trying to do the opposite of that. And clinical information systems design has to do with funneling relevant clinical information to the point of care for the clinician to aid them in their decision making. An example of this is getting the pop-up reminders that your patient is due for a PHQ-9 or for their colorectal cancer screening. So what is the evidence for collaborative care? Over 20 years, there's been 79 randomized controlled trials with 24,000 participants. It was considered a best practice by the Surgeon General in 1999 and recognized an evidence-based practice by SAMHSA. There's evidence for it in diverse populations, in the safety net populations, ethnic minorities, and helps to reduce healthcare disparities. It's for more than just depression. There's evidence for bipolar disorder and schizophrenia. I'm going to talk about two seminal randomized controlled trials in a bit more depth. The IMPACT trial and the Team Care trial. And I'll talk a little bit about the example programs that have implemented this model of care. So this is a meta-analysis, systematic review of comparative effectiveness of collaborative chronic care models for mental health conditions across various settings. In order to have been included in this meta-analysis, each of these randomized controlled trials had to have fulfilled at least 4 of the 6 components of the chronic care model that I described earlier. And so you see that there's an overwhelmingly better outcomes for chronic care model when compared to the comparison model, which is the care as usual model. And you see that it's not only in improvements in depression scores, but also improvements in mental quality of life, physical quality of life, overall quality of life, global mental health, and social role functioning. This is the same data, but categorized, but organized in diagnostic categories. And you see that the majority of the positive evidence is for depressive disorders, but there is some evidence for bipolar disorders, anxiety disorders, and other mental illnesses. I want to highlight that collaborative integrated care has evidence for not just decreasing PHQ-9 scores, but on short-term improvement in social functioning and long-term improvement in social functioning. So the IMPACT trial, IMPACT stands for Improving Mood Promoting Access to Collaborative Treatment. This was the randomized controlled trial which was done in 18 primary care clinics, 8 healthcare organizations across 5 states. It had an N of 1,801. Patients were 60 or older with depression, dysthymia, or both. The intervention arm included 12 months of depression management. The care manager was usually a master's level therapist or level therapist who was supervised by a psychiatrist and who was working with a primary care provider prescribing medications using evidence-based guidelines and expert advice from the psychiatrist. And they were either given the option of the medication management or brief psychotherapy, which was characterized by 6 to 8 sessions of problem-solving therapy. And for patients who had a partial response to an SSRI, their treatment was augmented with therapy or another antidepressant. Usual care was whatever was available in the community, and so that varied along the different sites. And so in some sites you may have had a PCP prescribing medications on their own with a therapist across the street or a therapist co-located in the clinic, or they were sent to a psychiatrist across the street and they managed everything in that clinic. And what we saw was a 50% improvement in the intervention arm versus a 19% improvement in depression scores at 12 months. The economic results were that an investment of $522 per patient yielded a $3,363 cost savings over 4 years. So the return on investment was $6.50 per dollar spent. The patient satisfaction was excellent or very good in 76% of those who were surveyed, and the patients who were in the study. And so the IMPACT trial showed that collaborative care for depression meets the triple aim, which is improved patient experience, improved quality of care, and cost effectiveness. And here's another representation of the depression results, depression score results of the intervention versus usual care. Then the participants in IMPACT were looked at again 8 years later, and we looked at cardiovascular events, hard cardiovascular events, fatal MI or non-fatal MI, fatal stroke or non-fatal stroke, and what we saw was a decrease in the risk of a hard cardiovascular event by 50%. and the number needed to treat was 6.1 over 5 years to prevent one event. So this paper argues or asks the question, should collaborative care be considered a primary prevention strategy for cardiovascular disease? The team care randomized controlled trial was for collaborative care for patients with depression who also had complex medical chronic diseases. And this was a smaller study because it was also focusing on a smaller population as well that was more complex. Used the same intervention as the IMPACT study, and it focused on patients who had diabetes, uncontrolled diabetes, coronary artery disease, or both, plus depression. The intervention used RNs as care managers who also managed the patient's hypertension, depression, hyperlipidemia, and A1C, diabetes control, and also supervised by psychiatrists and recommendations implemented by the PCP. At 12 months, you saw a 60% versus a 30% improvement in depression, 36% versus 19% improvement in at least greater than 1 point on the A1C, 41% versus 25% improvement in at least 10-point decrease in systolic blood pressure, and LDL was decreased by 14.9 points versus 8 points. And so now I'm going to talk a little bit about how these randomized controlled trials were implemented in large programs. You may have heard of Diamond. Minnesota is really well known for this project, done through the Institute of Clinical Systems Improvement, or as we call it, ICSI. Diamond stands for Depression Improvement Across Minnesota, Offering a New Direction. Basically implemented the IMPACT study using 6 commercial health plans, 25 medical groups, and 100 primary care clinics with 12,000 patients. The outcomes revealed a 16 to 28% better response rate for depression and a 20 to 34% better remission rate for depression. The other example program is MHIP, or Mental Health Integration in Primary Care, done in Washington State through the University of Washington, included 140 primary care clinics, staffed by 5 FTE psychiatrists, so that means 5 full-time psychiatry positions. That was spread across 20 psychiatrists for the state, and they've served over 35,000 individuals since 2008. This focus on primary care clinics and safety net, rural, and populations with a large proportion of ethnic minorities. The conditions targeted went beyond just depression, but also focused on serious mental illness, anxiety, PTSD, substance use disorder, ADHD. And the outcomes so far have been positive, seeing a reduction in homelessness and recidivism and incarceration. The COMPASS project, also done through ICSI, stands for Care of Mental, Physical, and Substance Use Syndromes, and now this was the team care randomized control trial implemented broadly. This included 172 clinics across the U.S., multiple states, 3,609 patients who had uncontrolled chronic disease, depression, diabetes, or cardiovascular disease, and this included public insurance as well, Medicare and Medicaid, as well as commercial. The results at 12 months showed depression remission of 40%, glucose control of 23%, and blood pressure control at 58%. So now I'm going to switch gears and start to talk about what collaborative care actually looks like on the ground and what this model feels like when you're working in it. So I'm going to start with a quote by Lori Rainey, who wrote the Integrated Care book. Collaborative care is an evidence-based systematic approach in which primary care and behavioral health providers work closely together to deliver effective treatment for depression and other common mental disorders in the primary care setting. It represents one opportunity for psychiatrists to leverage their unique skills and reach a larger share of the millions of people living with mental health and substance abuse problems in need of quality care. So integration into primary care exists on a spectrum. On the one end of the spectrum, the least integrated is specialty mental health care, where we're separated, where I spend half of my time, where I see patients in a clinic that is in a separate space from primary care. We focus on serving patients with serious mental illness or severe and persistent mental illness. Your focus is on long-term treatment and long-term stability. You have longer psychotherapy sessions and long-term psychiatric medication management. And this model of care is characterized by long wait lists and full panels. And so you often have boom and bust access to this kind of care, depending on how many psychiatrists you have, how many psychiatrists went on leave or left. And then the other model of care that's slightly more integrated is co-located care, where you take that same mental health professional, you put them in the primary care setting, and they do the same exact work. They see patients for long therapy sessions. They don't necessarily move the patients off the panel. You end up having the same problems, but now those problems are felt more locally, where you've got long wait lists and full panels. Primary care behavioral health or collaborative care is on the other end of the spectrum of integration. You use the same space as primary care, and that mental health professional now actually tries to treat the broader primary care population. So you're treating the same patients as the primary care doc. You are focusing on immediate access, shorter appointments, and brief psychotherapy protocols, so up to 6 therapy sessions per patient per episode. And you've got a psychiatrist working in a consultative role, not doing any of the prescribing, but helping a PCP manage their panel of patients, and oftentimes not seeing the patient, but helping the PCP make decisions about what medications to use. Sometimes you do see the patient. And you also help the PCPs refer the appropriate patients to specialty care who do need that higher level of care. And so here is the continuum of behavioral health care for our community clinics. We've got specialty psychiatric care at the top of the pyramid, focusing on long-term therapy, the serious mental illness population. So this focuses on the patients with the greatest degree of severity, complexity, but it's also the smallest population. Primary care focuses on patients who are less severe, but also a broader population, and they're pretty good at screening for mental health conditions, maybe initiating an SSRI and providing some education about depression or anxiety. But there's an enormous gap in care for the rest of the population that falls in the mild to moderate complexity range. And that's where we come in the integrated care setting. So the collaborative care core principles are population-based care, measurement-based, patient-centered, evidence-based, and accountable care. And I'll go through each one of these individually. The last thing I just want to highlight again is that collaborative care is not the same thing as co-located mental health care. We're not just taking a therapist or a psychiatrist and having them do the same work in primary care. They join a team, and we know through the evidence that collaborative care is superior to co-located care. But co-located care is often the step before you actually do more integrated collaborative care. So collaborative care is population-based care, which means we're focusing on a population or community, and so we have to ask ourselves, who is our population, who's the denominator we want to serve? I think a lot of mental health professionals are trained to provide care to individuals and focus and specialize in a particular set of diagnoses. But we're sort of trying to shift that and focus more on what are the needs of the population. I think sometimes that medical mental health professionals like nurse practitioners, psychiatrists might feel a little bit more comfortable in this population model because of the training that we get in medical school about epidemiology and public health care. But we have other weaknesses too, which I'll go into later. So, which is why we need a team. Measurement-based care is another principle. This consists of 2 tools or 2 strategies. That's stepped care and the registry. This allows for systematic follow-up and tracking of your population and make sure that nobody falls through the cracks. It also focuses on relapse prevention. We know that most mental illnesses are relapsing remitting conditions, and so it's really important to follow a person with depression for a year after the fact that after they've gone into remission, because their chance of relapse is high. So I'll talk about step care and the registry individually. Step care, when I explain this to my PCPs that I work with, is the arch nemesis of clinical inertia. This is the opposite of set it and forget it. Oftentimes PCPs will just start an SSRI and just hope for the best, but most patients need more than that. They need aggressive changes and adjustments over time. This follows evidence-based guidelines, and it's in consultation with a content expert, a psychiatrist, on a systematic level, and not just ad hoc case-by-case consultation. Part of it is identifying the most appropriate level of care as soon as possible and getting your patient referred there and connected to that level of care. So I explain this to my PCPs using a traffic light scheme, and I say, the patients that are green light are the ones that can stay in primary care. You could probably manage them with some support with, like a patient with major depressive disorder plus an alcohol use disorder. Have them see the therapist for a number of behavioral activation sessions, start them on an SSRI, maybe naltrexone, and hopefully they'll be able to stay in primary care. Then you've got your red light patients who are, right from the get-go, that they're going to need a higher level of care, higher intensity care, and maybe a completely different setting. And so these are your patients who have got schizoaffective disorder with multiple substance use disorders, maybe a personality disorder, and they're going to need to be seeing a psychiatrist long term. And so you try to get them there as soon as you can. But we know that there's long wait lists. So your patient that you're going to be prescribing their 2 mood stabilizers for might not be able to see a psychiatrist for 2 or 3 months. And so I'm here to help you kind of hold on to that hot potato until you can pass them off. And then you've got your yellow light patients where you're not quite sure. These are your more moderate complexity patients, and they might be able to succeed in a primary care with some more aggressive treatment and medication changes with therapy in primary care, but they may also need to be sent to specialty care. So you'll give yourself a little bit more time with these patients. This might be a patient who had acute stress disorder and then that developed or progressed to PTSD, and they might have a substance use disorder. You're not quite sure where they're going to end up, but you ought to try treating and helping them where they are right now. Panel management is the registry, so that's just a fancy way of saying this is an Excel spreadsheet where you're monitoring your patients. Why track? Well, because 30 to 50% of patients will have a complete response to the initial treatment prescribed by the PCP. 50 to 70% will need a change in treatment in order to go in through remission. And I'm going to talk about patient-centered care, and no talk about integrated care should be given, I think, at the University of Minnesota without talking about Dr. C.J. Peak, who's a national leader in the integrated care movement. And this is from his lexicon of behavioral health integration in primary care. So patient-centered care is the experience to the extent the informed individual patient desires of transparency, individualization, recognition, respect, dignity, and choice in all matters without exception related to one person, circumstances, relationships, and healthcare. Or nothing about me without me. This is something that we say in psychiatry all the time. It's part of the recovery movement. I tell my PCPs that don't talk about a patient don't say anything about a patient that you wouldn't be okay with them hearing. Don't write anything about a patient in their chart that you're not going to be okay with them eventually reading. So patient-centered care also refers to the fact that the patient is on the team and you're using team-based care. One of the things that we're not as good at as mental health medical professionals is thinking about teams. We're trained in a biomedical, hierarchical, top-down kind of culture in medicine, but we need to be thinking of the team, which is the patient, the PCP, a care manager, a behavioral health professional, and a psychiatrist. None of us is as smart as all of us, so we can get a lot more done together than we can individually. And this often feels like you're kind of a fish out of water because of the culture change. So this is what collaborative care looks like in action. You'll see that the bidirectional arrows have different widths, and that represents the amount of contact that each individual team member has with the other. And so you'll see that the PCP, the psychiatrist, and the care manager, the behavioral health professional, is focused around a patient population. And you see that the PCP has the most contact with the patient population. The behavioral health professional has a little bit less, and the psychiatrist has the least contact, least face-to-face contact, with the patient population, and is kind of remotely or in the background helping the PCP and the behavioral health professional on site manage the patient. So, for example, I work in 3 different primary care clinics, and so I'm part of 3 different teams that are, bringing patients who are a bit more complex to my attention, and we're kind of helping problem solve. So when I meet a patient, I usually tell them, hi, I'm a psychiatrist, I work on your primary care team. I'm just going to meet you one time, and that's in order to get a better understanding of what you're suffering with. I want to understand your diagnosis a bit better and understand what kind of treatments you've had, so that I can help your PCP and your therapist here come up with a plan that is going to give you the best chances for success. So collaborative care has to be accountable care, and this means payment should be based on performance and outcomes. Our current system is based on fee-for-service. Dr. Nelson was telling me that this morning you guys were having some discussions about healthcare model redesign. And this is, I think, part of that conversation, which is thinking about how the payment structures will change, and they've continued to evolve over time. And they will be more focused on outcomes and population management and less on fee-for-service, which is rewarding us for providing more care rather than necessarily better care. And this is, we're trying to really try to achieve the triple aim, which is improved patient experience, improved outcomes, and reduced costs. So now I'm going to start talking about the implementation process at HCMC. I'll talk about our needs assessment, our implementation interventions, and some of the preliminary outcomes. So we looked at our population characteristics, defined our denominator, looked at the prevalence of mental illness in the population, asked our PCPs what their expressed needs were, and did a deep dive in engagement into specialty care when a person was actually referred and there was access. So the HCMC population is characterized by mostly an urban patient population who experience many social determinants of health and mental health. Hennepin County has over 1 million residents. We do 800,000 encounters per year at HCMC with 200,000 individuals across the system. 35% of our patient population is white, 32% African American, 19% Latino, 4% Native American, and 2% Asian. Spanish, Somali, and Russian are the top 3 non-English spoken languages. Our interpreter service is really busy, using 78 languages and is deployed 12,000 times each year. Poverty is also another common factor, with 45% of our population being at 200% of the federal poverty level or below. We did a deep dive into the referral outcomes coming from the medical clinics in to our psychiatry clinic. And because I think one of the forms of pushback that we got from primary care was, well, if you're going to, if you really want to help us, why don't you just grow your programs and so we could keep sending our psych patients to you. And so we decided to take a look at that and look at the evidence for whether or not, even when they have access, whether patients actually make it or not. And over 2 years, with 6,227 referrals, 82% of those referrals failed. So the patient just never made it to see a psychiatrist. So making a referral to psychiatrists, I often tell PCPs, is pretty close to basically doing nothing. So that's just not going to be enough. We looked at what happened with those patients. So of the 6,227 referrals, 76% of them just never made an appointment. Their PCP said, you need to see a psychiatrist, and they just never did anything after that. The 23% that did make the appointment to see a psychiatrist, 74% of those patients did actually show up to at least one initial visit with a psychiatrist. That doesn't tell us anything about their long-term engagement or whether they showed up even for a second appointment. And so this was helpful for us to make that argument to primary care that we really need to be focusing on pre-engagement for our patients. The other thing we try to do is look at these referrals through the lens of social determinants, and we weren't able to look at all the social determinants because we were using EPIC or electronic medical record data, but we did see a pattern emerge among race and trauma history, which was not surprising, especially for the trauma history. We saw that African American patients were significantly less likely to make it to an appointment than Caucasian patients, 16% versus 19%, and PTSD had a significantly were significantly less likely to make it to an appointment versus substance use disorder, 12% versus 26%, and not surprising knowing that avoidance is a hallmark symptom of PTSD. This was in line with another study that was published from HCMC looking at 161,000 no-shows, and they saw a similar pattern among ethnic minorities. So then we looked at the prevalence of mental illness associated with a primary care encounter. This was a snapshot. This is not true prevalence of mental illness in our community or in the HCMC population, but just looking at when a patient saw their PCP, did the PCP also code for a mental illness that they were trying to help them with when they were billing? And so you see a median of about 20%. There's an outlier clinic there of 75%, and that is a clinic that is designed to focus on the highest utilizers in the system. We asked our PCPs with an express needs assessment, how much access do your patients have to quality evidence-based behavioral health treatment before implementing PCBH? 100% said sometimes, rarely, or never. Overall, how important is it for you and your patients to have behavioral health consultation integrated into your primary care clinic? and 90% said very important or important. Our intervention, I'll show you the timeline of our implementation, our team structure, and how we adapted the model with available resources that we had, and some of the quality improvement guidelines that we've been working on and how we've been focusing on the education mission. You'll see that in the early 2000s that we co-located a psychologist in the medicine clinic, and not a whole lot was happening, or it was happening pretty slowly over the next few years. But then you see a rapid expansion, a rapid investment into integrated collaborative care in the last year and a half. Here are our primary care clinics. Not all the primary care clinics here are shown, but we've got 8 primary care clinics shown here, and they all have a psychologist level, a PhD level psychologist working at in an integrated way in these primary care clinics. We've got 5 of the 8 covered by which have psychiatric coverage. So we're still working on that, and we're really just implementing this in phases. And some clinics are going to be farther along the integration spectrum than others. This is our team. Our team leadership is Dr. Sizdek, the psychologist leader. Amy Mensch is our RN program manager. And we've got 2 psychiatrists and 1 nurse practitioner providing psychiatric consultation, and an RN care coordinator, which is nowhere near enough. And we focus on increasing our psychologist workforce across the system because of the complexity of the patients. We also have psychiatry trainees, psychology fellows and interns, and we'd love to have a psychiatry resident from the University of Minnesota, of course, rotate whenever possible. So the HCMC model was really focused on caring for the patients who fell into that gap that I defined earlier in that pyramid. Wasn't meant to provide a mini psychiatry clinic in primary care. It wasn't meant to be a replacement for traditional psychotherapy or to provide long-term med management for patients. We've done a lot of process improvement. We've looked at our psychiatry referrals and how those are being made because of how abysmal those results were that we looked at with patients' engagement. We've helped community clinics come up with behavioral health emergency protocols and have involved our community partners and stakeholders, including the police departments and ambulance crews across the different communities that they're located in. We've looked at rooming for agitated patients in primary care, de-escalation training across the primary care workforce, including medical assistants and RNs and PCPs and front desk staff. We've worked really hard on improving screening administration and best practice alerts for mental health conditions and screening. Right now we're focusing on depression and ADHD. And those guidelines will go live at the end of January. Our education mission is focused on having a psychiatry resident rotating through PCBH and medical. We've worked with medical students primarily in the Whittier Clinic. We've got a new psychology intern rotation, a psychology fellowship. We're part of the curriculum development behavioral science committee for family medicine. We've got internal medicine resident immersion, and we do regular teaching and lectures to the PCPs on common topics, and we do monthly lunch and learn about difficult or challenging cases with primary care nurse practitioners. Our outcomes, here is our 1-year pre and post intervention outcomes. Ignore the table there on the left because that included that outlier clinic where obviously you have a selection bias of patients who have the greatest need and you're going to see the greatest impact, so you might have some exaggerated results there. But excluding those patients, we have 287 less inpatient visits, 835 less ED visits, 229 less emergency psychiatry room visits. And conversely, this was really interesting. We actually ended up seeing an increase in primary care visits, an increase in engagement for a person's overall physical health or mental health through their primary care doc, and a major increase in the psychiatry clinic visits. And I think that part of the anxiety for specialty level psychiatrists is, well, is this going to take away business from us? And actually, no, it increases your business because you're screening patients better and you are identifying the unmet need of a population. This is just showing that we're being used. This is our psychology visits steadily increasing over time. We're not just sitting there. The PCPs are actually using us and we're becoming part of the culture. PCP satisfaction rated psychologist is greater than 9 out of 10. The psychiatric medication consult service is a little bit less than 9 out of 10, but this isn't a competition. So, PCP satisfaction, access to behavioral health services. You see that it was rated excellent, very good, or good by 95% of the PCPs. Quality of behavioral health services was rated as excellent and good by almost 90%. And you're seeing that our preliminary depression data is decreasing over 6 visits with a therapist integrated in primary care. We're looking at this with intention to treat, so we don't know if this really reflects how helpful the service is, because a person might drop out of after 3 visits because their depression went into remission. So patient satisfaction is really high, 4.8 out of 5 for an individual session, 9.4 out of 10 for thinking of your provider from a 0 out of 10, worst possible to best possible. Likelihood of recommending this provider to others, 4.7 out of 5. And so this is our team, and I just want to thank everybody I work with at HCMC. Continue to learn from them every day and to be inspired by them. And thank you to you guys for inviting me, and to HCMC for giving me a job. So thank you.
Thank you so much. We have a moment for some questions, but one I was thinking about off the top of my head, you mentioned that HCMC high utilizer clinic. Mm-hmm. Is this model in that clinic? And if not, why not?
Mm-hmm. Yeah, so the collaborative care model is practiced most adherently in the coordinated care clinic. So that's where you have all the components of collaborative care being practiced, and that's where you also see the greatest impact. And that's what we're trying to model for the rest of the services. But because of limited resources, mostly being financial, it's going to take some time until we can phase in all the other components.
I assume there's a desire on the part of the staff at that high utilizer clinic to integrate more advanced models.
Yeah, and so the culture shift there is a lot. There's a kind of I think a lower bar, or maybe less of a barrier in that clinic, because the PCPs who work there already really value treating mental illness and helping patients with psychosocial interventions. So, and then that really varies across the different primary care clinics. I think anecdotally, I'd say that for all of our PCPs, you probably have 33% of them, a third of them, who are really all about this model and really want to practice in this model. Another third who are open to it but not quite convinced and need some convincing. And then another third who are probably going to be late adopters, or maybe he'll never adopt and work this way. And so we've really been focusing our energy on the people who are really enthusiastic about it, and then hoping that some of the late adopters will eventually come on board.
Interesting. Dr. Jensen.
How about other systems like Alina, Health Partners, Prairie Care, the children's hospitals? Is there an initiative there that's similar to yours?
That's a really good question, and too bad Dr. Sizdek isn't here, because he actually knows that. He's been looking at other healthcare systems and comparing us a little bit more than, so I'm not as familiar with that. So I'd rather not comment just because I'm not sure. So, yeah. What he tells me is that we're pretty far along, but I haven't taken a hard look at that, though. Yeah.
I could respond a little to that question. The American Academy of Child and Adolescent Psychiatry for these 2 period initiative is in collaborative integrative care, which is really a big thing. I mean, throughout the nation, and it's something we just have to do. Locally, in fact, at the Academy meeting, Reed Sulik, who's a psychiatrist in our community, received a special award, the Simon Wally Award, because of his work in integrative care, which he is now carrying out in Prairie Care. And their program, which he talked to us about Saturday evening, was quite extensive, and that's embedding teams into orthopedic surgery, like Twin City Orthopedic Surgery, one of the biggest orthopedic groups in the whole country, and all over the place, doing quite what you're doing. Mm-hmm. So I think this is just to be really praised, and thank you for doing this. A thing that kind of is impressive to me is that in some of your studies you noted that it was needed that the psychiatrist spend more than 15 minutes with the patient to I think, give him his day and to be listened to and to be understood. I'm glad to see that sort of I hope that's making its way back in. But I do realize that the importance of even medication management is maybe all that may be necessary, and others can do the rest. So hope you continue.
Yes, thank you.
Thank you. Thank you. That was great. You mentioned the triple aim, and the results are really impressive on that. Some people in the room may not know it's been expanded to the quadruple aim, which includes the health and satisfaction of the providers, given high rates of burnout. And I'm just curious if you can comment on that at all in terms of all the people on your team there and feedback that you've received.
Well, so the Compass project just published burnout levels using this model of care among their providers, among the care managers. And I don't recall the exact numbers, but they had positive results when comparing to the usual traditional model that we use, that this had decreased burnout. I could tell you from our team, we haven't measured burnout levels on our team, but I think we have a really cohesive group of providers who really enjoy working with each other and find a lot of meaning and purpose in the work. Dr. Feeblecorn is one of those providers, and she's here, so I'm really happy. I could speak for myself, but yeah, I think that's a great point, because as the other issue is that our workforce is declining, and so we need to be focused on keeping the providers, the psychiatrists, the psychologists, other mental health professionals who do want to keep working in this setting, keep them healthy and keep them productive.
Thanks for your presentation. You know, one of the questions that comes up in my mind is, you hear about the University of Washington model, and you kind of hear it's been sort of very nicely sort of systematized now. People are trying to port it, are trying to adapt it, and yet inevitably models develop in response to the constraints, both measurable and unmeasurable, the culture of where they are born, and then have to be adapted or modified, sometimes in subtle ways, sometimes not so subtle ways, as they're moved into other systems, other locations, and so forth. So I'm just curious, what have you noticed that you've had to tweak or do differently?
Yeah. Well, so at the University of Washington, the culture of integration was just much farther along. They had grants so that there wasn't the financial constraints that we have. And so I think the biggest barrier or pushback that I've gotten here is just always revolves around finances and kind of constantly having to prove that your outcomes, your intervention is worth it to the system. Because this model of care is not a money maker, it's a money saver. And so I think the differences have been convincing upper leadership that this is a worthwhile model, and then in the end is actually financially smart and cost effective.
So have you had to put certain metrics in place that they will follow or you will follow?
Yeah, so we've got our RVU goals that we still have to meet. I think that that's basically sort of equivalent to the rest of the department as far as what is the minimal amount of RVUs that you have to produce. And so what we've done, I think, is had to really think hard about how do we bill for every possible bit of work that we're doing. And so one thing that has been a really big help for our program is the Medicaid code that the Minnesota DHS actually pays for provider-to-provider consultation. And so I'm able to show that, I don't have patients for those 2 hours in the morning, but that doesn't mean I'm not doing anything or just catching up on my notes. I'm actually helping PCPs make decisions about their patients, and I get to bill for it, and I show that there's some productivity there in order to keep ourselves accountable. And Medicaid will expand that billing code in 2017 as well, so that'll be helpful. I think we need to continue to just be thinking really hard about how do we bill for the work that we're actually doing. Kind of think like lawyers a little bit sometimes. So,
your financial people, are they going to be tracking healthcare expenditures for people who are enrolled?
Yeah, we have to track them. No, not really. I mean, they don't actually track them because there still isn't. there isn't enough of a penalty for not tracking that. I mean, and payers will still pay you. I think that the economics of insurance and healthcare hasn't changed, and that's going to continue to be a focus regardless of what happens to the ACA or how that changes. So.
Maybe do one more here.
I noticed that social work isn't in your lineup.
Yeah.
And I wonder if that financial barrier is coming to play there because we can't bill for services unless we're doing psychotherapy.
Yeah, that's, the social workers in our model are part of the team, but they're through the primary care service line. And so, they're there, they're just not, I'm not mentioning them just because they're not. I mean, this is the other problem of integration is when you look at cost centers is that psychiatry has their own silo of money, and then primary care and internal medicine has their own silo of money. And so I'm coming from the Department of Psychiatry and just sort of more psychiatric centric.
Well, I think of the patient population that you're serving and how social work in that population would seem to be so critical.
Yeah, absolutely. And that's our direction forward is to now shift towards looking at master's level therapists and social workers at HCMC. Yeah. Oh, there's one more question. Maybe I'll take that. Yeah.
Thanks for your talk. I was wondering if the payers are interested in working with you on this, broader idea of saving costs. Are you collaborating with any of the specific payers?
Yeah. So ICSI, the Institute of Clinical Systems Improvement, works. That's kind of their role is to work with payers more on that. I haven't spent a whole lot of time and energy looking at that, but I think that's a really good point. So part of the issue too is, I'd rather be doing the clinical work than negotiating with payers. And that's not really, my specialty anyway. But yeah, we need to be negotiating with payers more aggressively. I think that's my opinion. So.
Or just for working on projects with it, let's follow this patient population over time.
Yeah, there's I can't remember which insurance company it is, but we have a consultant from that. And they've got this grant money, and they're calling it innovation, and I'm a little skeptical about it because what they're calling innovation is they're trying to push us towards innovation, but we keep saying that we have evidence for another model that actually has been shown to reduce costs. So I think we're past the let's think of some new ideas phase. We're in the we know what works, let's just do it phase. And that's unfortunate that they've kind of focused on some of these like boutique practices or ideas rather than just doing what works. But yeah.
Thank you so much.
Thanks. Thank you. That was good, really good.